I'm Jenny Childs. I come from the posh end of Yorkshire, in Harrogate, where a lot of people speak more like me. I've got a very, very difficult task because I've been asked to talk about a whole healthcare economy approach to antimicrobial resistance. And all I can say is, my goodness, what a day we've had. How do you follow some of the speakers that we've seen today, or that we've heard today? And a lot of what I might have said has been covered in much more detail and very well too. And I don't know about you, but it's certainly given me quite a lot that I'm really excited about, and we're certainly going to go and have discussions about when we get home. Now, what I've decided to do is take a rather different approach. Okay, it's been a good day, but you've heard a lot of data, so I'm not going to sit and bombard you with more data. What I want to do instead is actually, perhaps a bit like the last speaker, is to encourage you to think and reflect about what you're doing and how we might be doing it best. And I realise that that might be a bit provocative, and it's at this stage that I need to say that the views are my own and not of any trust past or present, nor the Journal of Hospital Infection, which I was editor-in-chief of until fairly recently. Now, antibiotic consumption. Okay, this is a data from the ASPAR report, which is the English report on antimicrobial prescribing. And the point of this slide is to make the point that most antibiotic prescribing is actually in the community. And something like 11% or thereabouts is prescribed in hospitals, and then you've got dentistry and podiatry under that. So that blue line up the top there, I don't know if you can read it along the bottom, that represents antibiotic prescribing in general practice. So a lot of us are hospital-based, and we're thinking about what we can do in hospitals, but actually most of it is out there. And then I guess, strictly speaking, you've got to add veterinary use on top of that somewhere. Now, when you look at what it's prescribed for, we've heard a lot about UTIs today, and that's a really good thing to say, because that's something realistically we could do something about. In fact, most antibiotic prescriptions are for respiratory tract infections, well, allegedly, anyway, which is rather more difficult, I think, for as I'll discuss in a minute. Now, whole healthcare economy is a phrase that's bandied around, and the first thing I did was think, well, hang on, what do we actually mean by that? And it's obvious, isn't it? We've got the acute sector, that's us, the CCGs, GPs, and I think in the yellow box you could probably add the social care sector to that. Somewhere in there you've got to put the vets. But I suggest that there's a third partner in that who is no less important as any of the other two, and that is the general public and patients themselves. Because a lot of the GPs tell me that one of the reasons that they end up prescribing when really they feel uncomfortable about it is Mrs. Barraclough is actually putting a lot of pressure on them to write out that prescription. And at the end of a busy clinic, what's the easiest option? So general public and patients, a lot more difficult to think about, but I think we need to include them. Now, we've heard a lot today, and I don't know if you can see this, it's the wrong colour background, but the whole business of antibiotic resistance have got so many components to it. There's stewardship, there's sequins, there are performance indicators, there are bacteremias, and all of a sudden it starts honestly to get a bit overwhelming, or at least that's the way it seems to me. So I think there are 4 questions we need to ask about antibiotic stewardship and antibiotic resistance generally across the whole patch. First of all, what could we do? What difference could I make? What should we do? There's a lot we could do, but we can't do everything. What's the best way of doing it? And I think a difficult question, how are we actually going to know if we're really making a difference? Now, antibiotic resistance, there are several components to it. We've heard quite a bit about stewardship today. Infection prevention, preventing that UTI in the first place. You're going to do a lot then to have a knock-on about reducing antibiotic prescribing for that, and the less prescribing you do, as was shown very nicely by Annie this morning, if you get a control on the antibiotic prescribing, you're going to go a very long way to getting resistance rates down as well. Infection control, very close to a loss of our hearts, but I can tell you, this has never been more important than it is now. It's a shame Professor Lieper has gone, really, because antibiotic resistance could well threaten a lot of what we think of normal of now. And let's face it, this is personal, you know. This is about me. This is my hip replacement. This is your prostatic biopsy, your cancer chemotherapy that potentially is going to be put at risk or even impossible years down the line if we don't do something about this. And to go back to the general public point of view, infection control, hand washing, you know, you've only got to linger in a public toilet to realise and watch what goes on at the hand basin, that actually hand hygiene isn't part of our culture at all. I mean, never mind what goes on or doesn't go on in hospital. You know, it's a much more fundamental problem with that. And then lastly, as I've said before, it's a battle of hearts and minds to engage our colleagues out there in the community, to engage care home staff, to engage GPs, and to engage the general public and their expectations around this whole issue. Now, if anyone's wondering what on earth to do, don't worry about that. There's a huge amount of guidance around there. And in fact, if you read everything, there will be hundreds of documents, thousands of pages worth of papers that you could go. And if you start now, you're probably just about finishing by the time you retire. Some of it's useful. Some of it is really useful. Some of it, perhaps less so. And this, for what it's worth, is I think one of the most useful resources. And this is a PDF that has been put together by Public Health England fairly recently, which has got links to all the key documentation that you could ever need, and some more besides that. So well done, PHE. This was a really useful thing. Now, I think there are really four bits for me that are the most useful. Start, that Smart, then Focus, and the Target toolkits are the two toolkits that will talk about things you can specifically do, messages that you can take out there to prescribers. And Start, Smart, then Focus, very simple. All you've got to do is review the need for that antibiotic at 48 hours and then take one of 5 steps. Really simple stuff. Some people I know have even got that on the end of their email signature. The SPAL report as well. Lots of detail in there about antibiotic prescribing in England and Wales, and and how that is changing. The PHE fingertips tool as well, which was mentioned this morning, and I'll show you a little bit of that in a minute. So some really good stuff there. But I mean, me and my team have been thinking about this, and my colleagues, and you know, sometimes this feels completely overwhelming, this whole agenda. And so what we've decided to do is literally take it one bite at a time, and think of a couple of things that we can do that might make an intervention. Now, the link, you know, antibiotic resistance is the same issue as stewardship, and to my mind anyway, the gram-negative bacteremia agenda is really just another side of the same coin, because the two are very closely linked. So we're going to take the urinary tract infection and the catheter thing as our starter for 10 on that. But we're doing an awful lot more about that anyway. Now, at this point, you're going to start thinking, well, actually, what works? And we've heard some brilliant stuff today, and I was particularly excited to hear all the stuff about dip or not to dip as an intervention of how you can really make a difference. But as soon as we start thinking about what works, someone's going to talk about, well, where's the evidence? Now, this is a particular, as an ex-journal editor, this is a particular bugbear of mine. And I think I'm going to make myself unpopular now, but I'm going to say this anyway. I want you to imagine you're up there, coming back from a conference on a military aircraft, and the engines have packed up. And the order is given by the pilot to bail out. And you're there at the hatch, and you're struggling with the parachute, and you've never done that before. And you're making a bit of a meal of it, and the doctor behind you pushes past and said, oh, for God's sake, there's no evidence to support any of that, and jumps. And as you watch him getting smaller and smaller, you realise that actually he's just made a very valid point, because there's never been a multi-centre randomised controlled trial looking at the impact of parachute use on the outcomes of death or major trauma following jumping out of a plane at 30,000 feet. Now it's your turn to jump. What are you going to do? Now, I see some of you smiling, but actually that's a serious point, because it's that level of logic that we use in the NHS quite a lot. And that phrase, well, there's no evidence, quite often that means something along the lines of, well, I don't want to do that, but it sounds better. Now, a couple of years ago, I was at a conference a bit like this, and listening to an infectious diseases physician talking about, I can't actually remember what now, but one thing he said as a throwaway line I think will stay with me forever. And he was describing the moment when he had volunteered to go and work in a Ebola hospital in Sierra Leone. And he described queuing up for PPE, to be issued with this PPE for the very first time. Now, I can imagine that was quite an emotional moment, and probably quite scary. And then he said this: I put on that PPE as I'd been trained to do, even although I knew there was no evidence to support its use. Now, just think about that for a minute. I thought, wow, that is an amazing thing to say, and how sad. But actually how dangerous. But we kind of accept that now. We're expecting a randomised controlled trial for everything, and there isn't. You know, the game that we're in, whether it's antibiotic stewardship or infection control, you will not have randomised controlled trials in absolutely everything, either because it's impossible, nobody's ever going to do it, or it's unethical. Ebola and an aeroplane jumping are two extremes, and I'm exaggerating, of course, but it happens all the time. The other thing, the point to say, is that this is a behavioural science we're involved in, and in behavioural science, you don't have randomised controlled trials. And when I was running the Green Journal, I actually had to go out and find an academic social scientist to take all those sort of social science, behavioural type papers, because they were so different from all the other things that we dealt with, and the normal reviewers that we used didn't know how to handle them at all. You know, they felt completely uncomfortable without p-values and regression analysis and all the rest of it, but they were no less valuable. For that. So just remember that. You won't always get that, but don't let that perception that there's no evidence stopping you from doing things. Now, once you've got past that, even if there is published evidence, you've now got the issue of organisational culture. Now, Michael Borg from Malta has spoken a lot about this in the context of infection control. And if any of you, if you haven't read that paper, that review in the Journal of Hospital Infection from about 3 years ago, I would suggest you do, because it's well worth a read. And he was basing his comments on some work done by Gert Hofstede on organisational culture, sort of across a wider field. And in a nutshell, what they were saying is what works well in one organisation or one country won't necessarily work where you are. And there are all sorts of reasons for that. But you know your organisation, you know how the people work. You may have to think differently. And in a large hospital, my last teaching hospital I worked in, the neurosurgeons were a totally different breed to the renal physicians, and we had to take a very different approach with them, and it was just all to do with those cultural things. So, in terms of prescribing, I think there are a few. The link between antibiotic prescribing and resistance is actually absolutely clear now, and we saw that this morning. Guidelines are crucial. Now, I'm sure there's been a lot written about guidelines, but this is what we've found to be important. They've got to be accessible and relevant, covering everything they need to, but above all, simple and clear and up to date. This isn't the place for doing a literature review. You know, if you want to do that, have links to all of that. But you've got to make it simple for people to find the right thing. I knew of one trust a number of years ago who had a policy. The fact it was impossible to find on the internet actually didn't matter at all, because nobody paid any attention to it whatsoever, least of all the microbiologists, one of whom had actually written it. And what would happen is junior doctors would phone up for advice on HAP, say, and every time they phoned up, they'd get a completely different set of advice. So they had to phone because you never knew what the answer was going to be. Now, some of the microbiologists actually quite liked that because, you know, there was this air that what we're doing is, well, it's sort of a dark arts to it, really, and made them feel, you know, quite powerful. And one or two of them actually admitted that. But the knock-on for that was that you got this strange layering effect. So patients would end up on about 4 or 5 different antibiotics, often for over, you know, a week or two at a time. Pharmacy had long since given up trying to police this. And one of the reasons for that was it was always done on micro advice. Now, micro could be anyone from a senior consultant down to the FY2. The point is, it was could be one of 10 people, so they never knew who to go to ask for guidance, so they'd just completely given up on that. And when one of the braver physicians pointed out that because of the way they worked, the very people who should have been promoting stewardship actually had completely the opposite effect, they decided, right, got to do something about this. And they completely redid the policy, and it took 6 months, and there were tears, and there were tantrums, but eventually they got a policy that they were all agreed to. And boy, what a day, I'm told, when it was passed through the Drug and Therapeutics Committee. It then took another 6 months to get that on the internet, because of all the hoops that it had to go to, all the other committees that wanted to look at it, all the middle-ranking managers who felt they had to put their stamp of approval on something they probably wouldn't have any understand. And that's an example of culture, departmental culture, and organisational processes just completely getting in the way. And what we're finding now at Harrogate is we're having to make substantial changes to our policy about every month at the moment, because to take into effect that this month we haven't got ceftazidime, last month it was ezetrinam, and we haven't got any tazocin anymore anyway. But we feel actually that's quite good, because it means we're continually having to think about what we do. We're continually sending these messages out. It's changed. You need to look at it. You need to think about it. But the point is, we agree it in the morning, and it's on the intranet and emailed round in the afternoon. Now, it's a lot easier to do that in a small organisation. I do appreciate that. But one of the tests I would suggest of how good it is this. It's the locum med reg test. How easy would it be for a locum reg who's never worked in your organisation before at 3 o'clock in the morning to find out what your recommendation is for, say, a hospital-acquired pneumonia, whether that antibiotic is available as ward stock or not, or whether it's something else that's going to need to get the ward pharmacist out for, or when does he phone a microbiologist for advice? How easy is that? The same is true in infection control policy. You know, you could argue the same for an agency nurse looking at your isolation policy as well. How easy is it to find? How easy is it to use? Because if it's something she's got to spend half an hour trying to plough through, it ain't going to happen. Other trusts have used this. Is anyone using MicroGuide or anything like that? Yeah, I wish we could. This is brilliant. This is, although I'm not endorsing any particular one, she says quickly, this is a smartphone app called MicroGuide, which is subscribed to by quite a few trusts in the UK now. And the point is, it's there. It's in your pocket. That's the way junior doctors get information for a lot of things these days. And you can continually update it, because every time you log on to the most up-to-date version. And some trusts have actually, gone way beyond the antibiotic bit, and their cardiology guidelines, renal guidelines, all sorts of things. Very useful. Now, the second thing. How do we know if we're making a difference? And I think this is a really difficult one, actually. A lot of antibiotic prescribing out there is about respiratory infections in general practice. I must say now, about 2 sputa a week from general practice, something like that. So that's not going to work. Urinary isolates, well, maybe, but not every urinary tract infection gets a sample sent for microbiology. So what we're looking at is almost certainly a skewed sample, probably exaggerating the resistance, but to quite what extent we don't really know. Blood culture isolates, yes, definitely. And I think I would also suggest C. diff as a surrogate marker of antibiotic prescribing generally, and that's borne out by the national data that was published in the Lancet Infectious Diseases back in February. And also in Harrogate, we've had extraordinary results with C. diff over the last 6 months. We've gone from being one of the outliers, not in a good way, in the region, to having none, well, unless there's been one since we've been here. We haven't had one since February now. And the thing that really made the difference, we think, is actually withdrawing coamoxiclav, which was being given to virtually everyone, including the porter who came through casualty door. And we've had a big drive on that. And the curve of coamoxiclav use decreasing mirrors that of C. diff. And I think we're just waiting now to see if we can get to a whole year with both of them being prolonged. And when we do, we're certainly going to proclaim that from the rooftops, because it's been really quite exciting. Sorry? Pardon? Okay. So this is the fingertips tool that was mentioned this morning. You can have endless fun with that. This is just looking at E. coli blood isolates in My Trust. You can look at CCG, what they're doing, the urinary susceptibility. Brilliant fun. So, and that's available on the PHE website, so do look at that. And then there's reaching the right spot and the general public. Years ago, I did a newspaper column. The equivalent would be a blog. Most blogs out there are for other microbiologists or infection control people. There are very few that are actually aimed at the general public, other than from government organisations or patients with an axe to grind. That's something you could do. So go away, think about that, have a go. Lastly, if I was Lord Sugar, I'd think about point-of-care testing in general practice, and a social media campaign. That we live in a post-expert society, according to Michael Gove. That's how people get their information now. Let's have a Facebook campaign about the role of microbes in health as well as disease, the importance of the microbiome, and antibiotics and infection prevention. So that's it really. I'm going to give up now. Don't give up there. And what I would say is it's difficult taking a hard look at yourself and seeing if your culture, if it's something about you, the way you work, the way your organisation work, is going to get in the way of all those things that you could be trying. But it's painful, but it's worth doing. So go for it and good luck.